higher creatinines, the relationship is curvilinear, 1 to 1. Then at a creatinine between like 0 and 2 or 2.5, it's pretty linear, and then it starts to go up curvilinear. So with patients that have normal renal function, it's probably fine to just with that creatinine. So 30% increase in creatinine is roughly the same as a 30% decrease in GFR, but it depends on where they are in their relationship between creatinine and GFR. So it's always fine. I mean, they should be reported right next to each other on the lab. Then serum potassium, again, we talked a bit about this already, but if it goes high, being above 5, you want to do something about it, probably not pharmacologic. If it's above 6, then you may want to hold the drug until it comes down below 6, do something to get rid of that excess potassium. Think about treatment on tumor or sodium saccharosylate. Yeah, so goals of therapy, monitoring of therapy, how to adjust therapy based on changes in your renal function and potassium. Those will be important. Side effects, contraindications. So a good focus again on the ACEs and the ARBs. Be very clear with not having some of this TDM. Complications of CKD. So the goals of therapy will again certainly be important because this kind of dictates how you start therapy and how you adjust therapy. So you need to know how to correct your calcium. So you need to know that equation. And then the goal is really just to avoid hypercalcemia, and that asymptomatic hypocalcemia is okay. But basically the target calcium is just the normal range. But if it's a little below and they're not symptomatic, that's fine. Phosphorus is not as clear. We tend to say towards the normal range, and so it's either the normal range or the old guideline is 3.5 to 5.5. The calcium times phosphate product is not recommended in the guidelines, but I think a good way to help us decide on some drug therapy changes that need to be made. The target there is usually less than 55. Remember to use corrected calcium in that equation when you multiply the two together. And then IPTH is less than 2 to 9 times the upper limit of normal for the assay at that institution, which generally is 150 to 500 or 150 to 600 is kind of the target. The first thing we do is we start defining phosphorus. That's because the pathophysiology, the first change that occurs is phosphate retention. So phosphate retention is the first change we see. We target that with phosphate binders. You select a phosphate binder based on their calcium. Right? And so if they have high calcium, you avoid the calcium-based binders. If their calcium is even normal, you probably think about avoiding those calcium-based binders because you're probably going to increase it, and that's not the goal. The goal is really to make sure that calcium stays in the normal range or slightly below it because of the classification. If you do want to pick a calcium-based binder, if their calcium is low to low normal, calcium acetate is typically the go-to. It has better calcium or better phosphate binding on its prescription, so there's better control over it from the prescriber's perspective. It has less elemental calcium, which is good because we don't want to give them too much calcium. It interacts with some medications, which we have a separate administration. Non-calcium-based binders, there are really two classes of now. It's the iron and non-iron based. The non-iron based, such as sevelamer, lanthanum, and aluminum, tend to be used more because the iron-based ones are more expensive. But sevelamer and lanthanum are still pretty costly in and of themselves. Sevelamer carbonate or Renvela is typically our first line non-calcium-based binder. Sevelamer HCl or Renagel is generally not used because it's got that HCl salt. Lanthanum is a good second line agent. Aluminum is often avoided because of the risk of aluminum intoxication, which can cause encephalopathy or hospitalization. Comparison there. The iron ones are ferric citrate and sulfur-ferric oxyhydroxide. Ferric citrate is useful because it actually provides a pretty good iron supplement to these patients, even in dialysis patients. This is the one iron formulation that is pretty well absorbed. So it reduces ESA requirements, it reduces IV iron requirements in these patients. But it is pretty costly, and the pill burden is still pretty high, 6 tablets a day to start with. And that's actually more than the starting dose of Sevelamer or Foslo, which is 1 tab TID. It's an iron, so it can discolor the stool that needs to be counseled on. And it is more costly from an insurance perspective, it's often not. It's a high tier or it's not covered unless patients have failed other therapies or start to. And sulfur-ferric oxyhydroxide, this one, the rule in therapy is that it has a low pill burden. And so again, it has a very effective phosphate binder, and 1 tab TID, which is a chewable tab, is very potent. And so oftentimes we can get patients from like 3 or 4 Sevelamer plus minus Foslo pills at each meal to 1 of these. So it's really reduced pill burden, and that's been shown with some evidence-based as well. The iron doesn't improve here though. It's iron-based, but it doesn't give them much iron. So if you want to treat their iron deficiency anemia, use ferric citrate. If you just want to reduce pill burden, use this one. Again, it's more expensive than others. Don't need to do others. Unless it's very short term or very severe. Take it with meals, right before or right at the first bite of meals. That's the most important thing. Making sure the patients know they have to take it every time they eat. Very important concept. The next thing you would do is you would address the patient's relative active vitamin D deficiency by treating them with active vitamin D. And so those choices are calcitriol, which is endogenous, or paracalcitol, or doxycalciferol, which are analogs, so those are exogenous. Doxycalciferol requires hepatic activation, so not good if they have prominent liver dysfunction. Paracalcitol is arguably the best one of these because it has the least risk of calcium and phosphate elevation. Remember, this is an active vitamin D product. It will cause the gut to absorb more calcium and phosphate. That is bad in these patients who are trying to keep their calcium and phosphate down. But that has to be managed with the other medications. So that's why paracalcitol is probably better. Calcitriol has the worst risk of hypercalcemia, but is the cheapest. And then calcimimetics would be the last one to use. This could be used in place of an active vitamin D if the patients are very hypercalcemic, because that active vitamin D is just going to worsen their hypercalcemia. A calcimimetic actually brings down their calcium. Right, so a lot of these decisions are made based on the patient's calcium. And so that's why one, correcting calcium is so important, and 2, paying attention to what else is going on in the patient's case is important. And so cinacalcet is the oral calcimimetic, started at 30 milligrams a day because higher doses cause worse nausea and vomiting, which are very limiting. It has CYP3A4 metabolism, so some drug-drug interactions. And then L-calcitide or Parsabiv is the new IV formulation of this. Not really used yet, just because it's expensive and dialysis is ready for it, and they pay for enough already. But it is an option for patients that maybe can't take the oral and have a strong indication for calcimimetic. There is an IV option.